Hello, everyone. Today, I'd like to talk to you about the underactive thyroid and the influences it has on chronic diseases and conditions, and how it's often missed. And I think it's missed partly because the blood tests are not fully helpful, and partly because people don't think about it as being part of the problem, and also because they might be looking at the wrong test. And there are things that interfere with the test as well. So there are multiple things that make it very difficult for an underactive thyroid to be diagnosed. Yeah. So just to remind you that this podcast is designed for general educational purposes only and does not replace personalized medical advice. Always consult your own healthcare professional regarding any individual concerns. Please share this, like, comment, and subscribe. Now, I've consulted with many patients over the years who have chronic illnesses like pain, fatigue, memory problems, sleep problems, inability to lose weight. I also look for an underactive thyroid in conditions like diabetes type 2, fatty liver, and I've even seen it in adult acne when I looked for all the other things that could be associated with this woman's acne, and the only thing I found was her underactive thyroid. So I treated that and the acne got better. So this is called hypothyroid. So to help you remember is hypo means low. Most commonly, it's an underactive thyroid that I see in practice. Very uncommon for me to see an overactive thyroid, which can be quite tricky to treat. So underactive thyroid is more common in women, and it runs in families, and it seems to become more apparent after menopause. Now, there are a lot of problems related to an underactive thyroid. I probably haven't thought of all of them, but people just don't think about it when they see these problems. And they include polycystic ovarian syndrome, endometriosis, restless leg syndrome, allergy, mood disorders and anxiety, memory problems, muscular pain and weakness. Typically with thyroid, it's around the shoulders, but it can be in other places, and it can mimic conditions like polymyalgia rheumatica or rheumatic conditions. Slowed kidney filtering, raised uric acid. Now that can be associated with gout, but also it's associated with diabetes type 2. Alopecia areata, which is patches of baldness, and underactive thyroid can be associated with many autoimmune diseases. And in fact, there's a triad of thyroid, alopecia areata, and anxiety. There's also another triad of thyroid, celiac disease, and osteoporosis. Underactive thyroid is associated with abnormal cholesterol, migraine, bladder pain syndrome, reduced fertility. It could be a hidden cause there. Age-related macular degeneration, dementia, heart failure, coronary artery disease, blood pressure, frozen shoulders, urticaria and hives, ringing in the ears or tinnitus, vertigo or vertigo, Meniere's disease. Did I mention frozen shoulder? Obstructive sleep apnea, difficulty losing weight. So how does the thyroid system work? Well, there's a chain of things going on in relation to your thyroid. The thyroid itself is a butterfly-shaped gland at the front of your throat. The original message for your thyroid starts in the primitive brain at the hypothalamus. That stimulates your pituitary to make thyroid stimulating hormone. And that thyroid stimulating hormone comes to the thyroid and stimulates the thyroid to make T4 and a little bit of T3, the active hormone. But T4 is the precursor hormone. And then in the tissues, the T4 is turned into T3, which is the active hormone, and reverse T3, which blocks T3. So that's how it works. And in the tissues, the active T3 hormone is converted from T4. And so in some conditions, it's difficult for the tissues or the body to convert the T4 to the T3. And I know that that can happen in diabetes as well, which is why I look for an underactive thyroid in diabetes. So when doctors are testing for an underactive thyroid, they really should listen to the patient's symptoms and examine them. But these days, your family doctor's very busy and they like to do a blood test for thyroid stimulating hormone, or TSH. And sometimes they do the T4 test, but I'm quite interested to see that they don't do the T3 test, which is the active hormone. And I find that intriguing. So that's how they diagnose underactive thyroid, with a TSH that's starting to go up because the pituitary's starting to send more and more TSH to the thyroid to get it to make T4 and a little bit of T3. So it's called Hashimoto's thyroiditis when you've got positive thyroid antibodies along with the slow thyroid. So I think a percentage of patients are not diagnosed. One of the reasons is that doctors generally don't measure active T3, and the laboratory, certainly our laboratory, can't measure reverse T3. So you're not really getting the active thyroid hormone. Now, on top of that, there are things that can disrupt your body's ability to make thyroid hormone and to function with the chain of thyroid things that are going on. So there are medicines that lower TSH, and that tricks the doctor, if you like, into thinking that things are okay, or that the patient's taking too much thyroid medication. And these medicines are steroids like prednisone, prednisolone, dexamethasone, hydrocortisone. Physiological amounts of hydrocortisone in the body play an important role in the variation of serum TSH levels. And the TSH levels are lower in the morning and higher at night. So you've got to remember that if the test is done in the morning, the TSH level will be lower, especially if the patient is on steroids, and then it'll be even lower. The problem with that is that I like to do the test 24 hours after the last dose. So I like patients to do the test before they take their first medication for the day. Now, other drugs that can artificially lower the appearance of the TSH is dopamine and dopamine agonist bromocriptine. And this medicine is used to suppress too much prolactin. Epileptic medicines like carbamazepine and valproic acid increase the breakdown of thyroid hormones through the liver, but might also alter the responsiveness of the body to hormone feedback and cause the pituitary not to stimulate the thyroid. So then the TSH goes down because the pituitary's not working properly, and the doctor might think that you're okay, or the person's having too much thyroid medicine. Metformin is used a lot, not just for diabetes type 2, but for prevention, because it has actions against cancer, protects the brain, protects the heart, and can lower cholesterol. So metformin, which is used a lot, can lower TSH levels, although we don't know exactly why. So there are other medicines and chemicals, lithium, amiodarone, both cause reduced thyroid function. As well as that, lithium can also cause goiter, which is the swelling of the thyroid, especially when it's used long term. So I remember a patient who was on amiodarone for quite a while for his atrial fibrillation, and I had to adjust his thyroid medication because he was becoming hypothyroid. Also, antidepressants, amino acids, aromatic dyes, flavonoids, which are plant antioxidants, can slow the thyroid. Some environmental chemicals like perfluorooctanic acid and other types of chemicals like nitrates, halogenated aromatic chemicals. Now, this means you need to look at a person's occupation because these chemicals are used in industry. Not only that, but what about gardening and the like? Because some pesticides and fungicides can affect the thyroid, including glyphosate, which is Roundup, organophosphates, carbamates, and pyrethroids. So these are all used for gardening. Now, on top of that, if you're exposed to heavy metals like arsenic, that has been used in sheep dip in some industries, that can affect the thyroid and increase the risk of thyroid antibodies. So I won't go into the details of how all these some of these pesticides, fungicides, and industrial chemicals affect it. But just remember, sometimes it stops the conversion of T4 to T3. But there are other things as well. So remembering that, if you're exposed to chemicals or you're in an industry, looking at these chemicals are quite important. So coming back to the TSH test, which is commonly used, there's also some other problems that make the TSH inaccurate. If you've got a zinc deficiency, your body can't make TSH from the pituitary. Not only that, but stress and disease of the body, which you need adequate T3, but you get less T3 and increased reverse T3, which blocks T3, is caused by any physiological stress, inflammation, depression, insulin resistance and diabetes, aging, dieting and calorie restriction, premenstrual syndrome, chronic fatigue, fibromyalgia, and obesity. So you've got to take into account any sickness that person has, any stress that person has, and any other things that are going on. And one of the ways that this happens also is that there's a messenger called corticotrophin releasing factor, or CRF, which the hypothalamus, the primitive brain, which is above the pituitary, releases under situations of stress as well. And so that suppresses TSH as well. Now, another cause of low TSH is when the pituitary gland just isn't working. It's sick. This can happen with age. It often occurs in very old people, but it can occur when you're younger. So sometimes when there's a very, non-existent TSH or very low, maybe you need to look for pituitary failure. So we know that TSH that is mainly used is not accurate. Now, on top of that, a few years ago, I had two patients that did the same thing. They did their blood tests twice, 10 days apart, because they forgot. And what I noticed was that their cholesterol and their thyroid tests were very different 10 days apart. So we rang up the lab, and then I got a letter telling me that they accept up to 40% variance, which is quite a lot, isn't it? So I'm not sure whether this means that you can't really use a thyroid test and follow it necessarily if your local lab has the same problem. So the other problem is that the T4, which is the precursor thyroid hormone, tends to get less conversion to T3, especially under illness and stress. So measuring T4 doesn't necessarily correlate with active tissue hormone T3 levels. There is one thing I do, however, is that when I do see a low T4 level, I then wonder whether there's enough iodine in the body, because the pituitary sends TSH to the thyroid, but in order for the thyroid to make T4, you need tyrosine, which is an amino acid from protein, and you need iodine. So if I see a low T4, I'll test iodine. Now, just as a side thing, iodine is important for prevention of thyroid and breast cancer, but it has many, many roles in the body. And many places around the world have iodine and selenium deficiency in the soil. And this is why in the USA, the salt was iodized in 1925, and in the 1930s, the salt was iodized in New Zealand. So researchers have deeply looked into the T3 levels and suggested that these T3 levels can be a guide to thyroid status, along with the context of that person's health conditions, their symptoms, and the findings on examination. You've got to always be aware that when you look at a T3 level, you don't have a reverse T3 level. So I find that sometimes I'm looking at what looks like a normal level of T3, and I've got a patient in front of me that's got all the symptoms and clinical signs of an underactive thyroid. So I'm going to listen to the patient and their symptoms and the context of their symptoms, because they've got all those conditions that I mentioned, or some of them. And then I'm going to look at their heart rate, their clinical examination, and then I'm going to make a decision. So there's no perfect test that you can use on a blood test. So you've got to look at everything. So in the past, I'll give you a little history that's going to help a lot of people, because you've probably heard about AMA thyroid, pig thyroid, glandular thyroid. So I'll give you a bit of history on that. So before my time, and I became a doctor in 81, before my time, doctors used desiccated thyroid, which came from pig or bovine thyroid. Bovine is cow. And that's all they had. And as time went by, they found that these products were not accurate. So synthetic T4 was created and offered to doctors. And that might be why the T4 test is used these days. The other thing that researchers have found is that looking at the clinical symptoms along with the ankle reflex seem to have a reasonable correlation. So the ankle reflex had a specificity of 93%. That means it's fairly specific for thyroid, and a sensitivity of 77%, meaning, well, it's reasonably sensitive. So looking at the ankle reflex is not 100%, but fairly good. So looking at the speed of the ankle reflex and the other clinical symptoms is going to be possibly more accurate than just looking at a TSH. Now, some experts say that you should measure all of these tests, TSH, T3, T4, and reverse T3, as well as thyroid antibodies, along with sex hormone binding globulin. But in practice, we have to be aware of, certainly in New Zealand, the public spend on tests and saving money. And, we can't get reverse T3, and we need to be sensible about the testing that we do. So what you've just heard suggests that there are going to be people who have not been diagnosed with underactive thyroid or hypothyroid that should have been. According to the National Academy of Hypothyroidism and Integrative Sciences, there are 20 million people affected by thyroid disease in the USA. And they suggest that sufferers that remain in an undiagnosed state are 50 to 80% of cases that are missed just by using the TSH test alone. So what we're told is that primary hypothyroidism should be diagnosed with a raised TSH and a reduced T4. But I've already told you about how inaccurate the tests are. The other problem with the tests is there are variations of range and cutoff levels that are used by laboratories. So one of the ways that the laboratory decides what its normal range will be is that they take a large number of apparently healthy people for that age and sex, and they test all of them, and they get this normal distribution curve. And you've probably all heard of this normal distribution curve. And they take 2 standard deviations from the mean, and they say that will be our normal range. Well, there's going to be a percentage of people who are hypothyroid with that test. So that test really should be further to the right or further to the left, depending on what you're looking at. And I've also perused the literature and found that the so-called ranges of TSH, or the upper level of TSH, depending on the country that you're in, can be 2.5 or up to 5.5. So how are you going to sort of work with that? It comes back to remembering to listen to the patient's symptoms and examining them. So what do? I listen carefully to the problems that the patient has, their symptoms, and any associated conditions that I've mentioned to you. I listen to the family history. I review a detailed thyroid questionnaire. I look at the blood tests, including a free T3 result, as a guide. And I look at the context of their symptoms. Do they have polycystic ovarian syndrome? Do they have endometriosis? Do they have fibromyalgia syndrome? A percentage of those people are going to have an undiagnosed underactive thyroid. Now, in my view, physical examination is important. And I was taught when I was training that after you've taken a good history, the patient must be examined. And a lot of the time when I've done this, they will say that they haven't been examined like this before. So what do I look for? Well, if we start at the top, I'm looking for Hertog's sign, and that's the loss of the lateral third, the outer third of your eyebrow. I look for fluid retention around the eyes, puffy under eyes I'm looking for. I'm looking for an enlarged and quivering tongue. If the tongue is enlarged, common causes of that are underactive thyroid, low magnesium, low progesterone. But if I see a quivering tongue, I think of mercury poisoning, but if it's not that, it's an underactive thyroid. Now, I also look at the hands. My hands are good, right? Are they puffy? Are they swollen, which is also the case with the face? Are they telling you that their body's swollen, that their legs are swelling? I look for dry skin, particularly around the elbows and legs. And mostly the commonest cause of yellow palms and soles is an underactive thyroid. And that's because you need active T3 to break beta carotene apart into 2 vitamin A molecules. So you need T3. So beta carotene is like this, and T3 breaks it into 2 vitamin A molecules. And that's why you get yellow palms and soles and dry heels. So I look for absent knee and ankle reflexes. I look for beading of the nails, which is vertical ridges along the nails. There are some other causes of beading, but thyroid, underactive thyroid, is a common cause. So I do know that patients say to me, my blood tests for thyroid have been normal, but I need to go through all of these things because I often see a normal blood test too. So it's very important to be cautious about diagnosing it You don't want to over-diagnose it because it'll thin the bones and put pressure on the heart. So that's very important. And when I'm treating a patient with underactive thyroid, I can use synthetic T4, which is on prescription in New Zealand. Sometimes I use only T3 if there's plenty of T4 and I don't think it's turning into T3. Sometimes I use both. So what experts are telling us is that they want to see a normalization of the TSH level. Well, that's got its problems, hasn't it? Because it's a blood test and it's not fully accurate for reasons that I've explained. So I do look at the blood tests, but I think that we're looking at improvement of the symptoms that the patient's got, that they start sleeping better, their mood improves, their energy improves, the conditions that they've got, like cognitive problems, fatigue, muscle aches and pains, the problems start to improve. The hoarse voice in the morning, the stiff joints in the morning. Sometimes it's the ringing of the ears or the restless legs. So coming back to the thyroid extract, that was initially developed in the 1880s. And as I mentioned, that was the only treatment. And it was the case that doctors used to sort of push up the dose, over-treat, and then pull back and get the right dose there. And the other thing that they used to do is that they would prescribe a 1-week holiday, and I'm not sure why they did that. Just giving you that background. And then by the 1960s, backed by 80 years of experience, and at the height of its use, it was believed that physiological doses of desiccated thyroid extract reproduced the same effects of natural thyroid secretion. But then, as you know, they had the problems, and then T4 came along in the 1970s. So that was before I graduated. So when I graduated, I just assumed that everybody used T4. Levothyroxine, Synthroid, they're brand names. But the problem with that is that some people didn't respond well enough to the T4. And I see people who are still hypothyroid even though they're taking T4. And in fact, when the doctor has put their T4 up, they get worse. So what's happening there? Well, the T4 is turning into more reverse T3, which then blocks their active T3. So a lot of the researchers have discussed synthetic T3 or liothyronine, which has been available since 1956. And that can be an add-on therapy to the T4. And they've found, and I've noticed in a lot of the literature, that they do like people to have some T4 and T3. So the British Thyroid Foundation recommended a therapeutic trial of T4 and T3 combination, stating that they want it to restore physical and psychological well-being. The result, however, of all of these things is that, generally speaking, most groups around the world regard T4 on its own as first line. And a survey done in 2019 showed that at least 58% of clinicians prescribe T4 only. Now, coming over to the T3, plain T3 reaches its peak in 2 or 3 hours and gets out of the system very quickly. So they've developed something called slow release T3, which I prescribe. So researchers have found that combining T4 and T3 does not increase morbidity or mortality. Morbidity means disease or problems, and it hasn't caused any problems related to heart disease, cardiac arrhythmias, and fractures, compared with having T4 only. And they think, these researchers, that the response to T3 containing regimens can be variable depending on genetics, environmental factors, and medical comorbidities. That means other medical problems. So currently, most evidence suggests that your first choice is going to be T4, and then if required, add in the T3. In practice, I look at where the patient is and whether they've got a lot of T4. If they've got a lot of T4, I may not give them more T4 because I'm worried that it's going to cause not enough T3 and too much reverse T3, which will block the T3. But each case is taken individually in my situation, in my practice. So ultimately, a lot of the researchers talk about a U-shaped curve, meaning that if the thyroid is too low, the body's not going to work well and you're going to have health problems. It needs to be just right, not too high, or you're going to get more cardiac arrhythmias, thin the bones, cause a lot of heat and a lot of problems. So really, it's about finding the sweet spot for that patient. And the way that that's done is using the blood test as a guide, looking at how all their symptoms are going. Are they sleeping better? Is the energy better? Have the stiff joints in the morning gone away? Has the hoarse voice in the morning gone away? Has the acne got better? Has their memory and concentration got better? Is their hair growing again? Because people lose hair with this problem. So really, I think I've given you all this information to give you some alertness about how thyroid is often missed, and it can be a very common participant in a lot of chronic diseases that women get quite a lot of. And I think that when patients are not progressing, it can be helpful to examine the situation with the thyroid in case it has a role with that person. So I hope I've increased your education, knowledge, and awareness of the role that thyroid has in a lot of conditions. This podcast is designed for general educational purposes only and does not replace personalized medical advice. Always consult your own healthcare professional regarding individual concerns. Please like, subscribe, share, and comment. See you at the next one. Bye for now.